My name is Greg Barsness. I am a interventional cardiologist and director of the Cardiac Intensive Care Unit at Mayo Clinic in Rochester, Minnesota. And I'm here in Boston, Massachusetts, having just presented at the 21st World Congress of Cardiology on a topic that I've recently become interested in, and that is delirium. I gave a talk called Delirium in the Cardiac Intensive Care Unit, More Than a Nuisance. Cardiac intensive care has evolved over the years, over the decades, from a observational sort of unit that involved early recognition and attempts to treat cardiac dysrhythmias associated with acute coronary syndromes. And it's evolved now to involve care of complex, multidimensional patients with very advanced disease. And that has led to a change in the sort of structure and function of the cardiac intensive care team. The team now involves multiple members who care for these patients and attend to all of their needs, not just the coronary process or not just the myocardial infarction, but in fact advanced heart failure and advanced need for supportive devices, mechanical ventilation particularly, and one of the major comorbidities associated with these other conditions is delirium. Delirium affects about 60 to 80% of patients in the intensive care unit. The impact financially is enormous. Both acute and follow-up care costs may exceed $10 billion a year in the United States. And more importantly, there is a mortality and morbidity associated with delirium in a dose-dependent effect. So the longer you're delirious in the hospital, the more likely you are to die. And if you survive, the more likely you are to have cognitive impairment that lasts for the rest of your life. And so delirium recognition and treatment is imperative. There's a lot of work in the critical care community to address these issues, and a variety of bundles of care and process evolution has taken place in critical care medicine. Application of those care bundles in cardiology has yet to be really explored. And so part of what I spoke about today was our evolution in the understanding of delirium and the application of these tools, including care bundles, to reduce the incidence of delirium or at least treat it. Measures to improve outcome might include spontaneous awakening and breathing trials, which have been shown to decrease length of stay by 4 days in the ICU, decrease mortality by as much as 20% in absolute terms at the end of a year after ICU hospitalization, all the way to things like early mobility, sedation, medication adjustment, and family involvement. So there are a variety of tools available to us through the critical care medicine societies and through cardiology collaborations, and application of these and further research into these tools will do a lot to improve our patients' outcome and improve the status of care in the cardiac intensive care unit.